Good afternoon, and welcome to today's webcast from the Agency for Healthcare Research and Quality on using AHRQ's SOPS Hospital Survey and Workplace Safety Item Set, Experiences from a State Hospital Association. My name is Lisa Huddleston. I'm a lead research associate at WestStat and the communications team lead for the contract that supports AHRQ's SOPS surveys, and I'll be the moderator today. Next slide, please. We do have a few housekeeping items. First, if you are having any issues with your computer audio, and you can connect to the webcast audio using your phone by clicking on the phone call to find the dial-in number and meeting ID, or selecting the call me option to enter your phone number and receive a call from Zoom. If your computer freezes during the presentations, you can try logging out and logging back in. At any point in today's webcast, you may ask a question through the Q&A icon. We encourage you to share your name and your organization or your role when you type your question. Speakers will respond to your questions during the Q&A segment at the end of today's webcast. So please note that both the raise hand and the chat features are disabled. You can currently download the presentation slides and view the agenda and speaker bios on our event website at https://events.westat.com/SOPS. In addition, a replay of today's webcast and slides will be made available soon on the AHRQ SOPS website. There's only one Zoom link for the entirety of today's webcast. If you leave at any time, you can rejoin using the link provided in the email you received after you registered. Next slide, please. Now I'm happy to introduce our speakers for today's webcast. We're very pleased to welcome Jonathan Backdash, who is the social science analyst for the Consumer Assessment of Healthcare Providers and Systems, or CAPS surveys, as well as the Surveys on Patient Safety Culture, or SOPS program at AHRQ. Representing the Indiana Hospital Association are Madeline Wilson and Laurie Gert, both of whom are quality and patient safety advisors for the Indiana Hospital Association. Finally, I'm also pleased to introduce my colleague, Naomi Yount of WestStat, who is the Instrument Development and Analysis Lead for the User Network for AHRQ's SOPS program. And again, I'm Lisa Huddleston, and I'll be moderating today's webcast. Next slide, please. Our agenda today starts with John Backdash giving a brief overview of the AHRQ SOPS program, and then Madeline Wilson and Laurie Gert will tell us about how the Indiana Hospital Association has used the SOPS Hospital Survey and Workplace Safety Supplemental Item Set with IHA's member hospitals. Following their presentations, Naomi Yount will provide a summary of research findings pertaining to how workplace safety culture is associated with patient safety culture, job satisfaction, and intent to leave. Finally, we'll end with a question-and-answer session. Next slide, please. So let's begin, and I will hand it off to John.
Thank you so much, Lisa. Hi, my name is Jonathan Backdash. I'm going to tell you a little bit more about AHRQ and give you a brief overview of AHRQ's SOPS program, Surveys on Patient Safety Culture. Next slide, please. So I'm going to tell you what AHRQ is and what AHRQ is not. So AHRQ is a research agency that is part of the U.S. Department of Health and Human Services, focusing on evidence-based practice. And AHRQ is the lead agency charged with improving the safety and quality of the U.S. healthcare system. One critical thing I want to point out is AHRQ is not a regulatory agency, so we cannot require the use of any of our tools or products. We're a research agency. So there may be requirements to use some surveys or other instruments that have been developed by AHRQ, but they don't come from AHRQ itself. Next slide, please. So AHRQ has these patient safety priorities: focus, extend, prevent, build, improve, make safety easier. Focus on the areas of greatest impact, extend patient and safety improvements to all settings, prevent, healthcare associated infections, reduce antibiotic resistance, build capacity in the healthcare system to accelerate safety improvements, improve communication and engagement between clinicians and patients, and make the safe thing the easy thing to do. Next slide, please. So AHRQ's surveys on patient safety culture program started in 2001, and it aims to advance the understanding and measurement and improvement of patient safety culture in healthcare settings. The SOPS program develops validated surveys and measures for use in facilities, using best practices for development and testing. The program also supports voluntary data submission to the SOPS database, and again, emphasizing the voluntary part. And another part of the SOPS program is research to conduct and further our understanding of patient safety culture and resources to improve it. The SOPS surveys are trademarked, which ensures they continue to be valid and reliable and have met certain criteria during their development and testing. Next slide, please. So what is patient safety culture? I'd like to give you a brief overview. Patient safety culture is the beliefs, values, and norms that are shared by healthcare providers and other staff in a healthcare organization. It determines what behaviors are rewarded, supported, accepted within an organization as they relate to patient safety. And what this shows is some of the behaviors in the top row here, and also it shows the different levels of an organization, a system that has multiple hospitals, a single hospital, departments within a hospital, and units. So patient safety culture is pervasive throughout the healthcare system. Next slide, please. So today we're going to focus on the SOPS Hospital 2.0 survey. And this is just an overview showing the 10 composite measures. So items like teamwork, communication about error, and also some single item measures that include the number of events reported and overall patient safety rating. This is just to give you a brief overview of what is being measured by the hospital survey. Next slide, please. So just a reminder, the database submission for the hospital SOPS survey is going to open very soon. It'll be open June 3rd through the 21st. And hospitals can submit their data that's collected between July 2022 and June 2024. And that also includes supplemental item sets that are administered with the core hospital SOPS survey. And we have one new thing for the supplemental item sets. Next slide, please. You can now do partial submission of supplemental item sets, so it does not have to be the entire supplemental item set, but the supplemental item sets should be administered with the core SOPS survey. Next slide, please. So every participating hospital that submits to the database gets a private feedback report so they can see how they're doing relative to the overall averages in the SOPS database. And a health system will also get a system level private feedback report. So in this example, you can see that with this example data set that the positive responses for most of the measures of teamwork are quite good, less so for the during busy time staff in this unit help each other out. That's the lowest one at 71%. And this is just an example to show to help identify areas for potential quality improvement. And this is a benefit of submitting to the SOPS database. Submission is free. The feedback reports are also free. And this gives you an idea of what the private feedback reports look like. Next slide, please. And just to give you a summary from the last hospital SOPS database report, the areas of strength on average for most hospitals were teamwork, with 82% reporting a positive response, and also support for patient safety by supervisors, managers, and clinical leaders. Whereas the area that had the most potential for improvement were staffing and work pace, which was about 50% positive response. I just wanted to give you a little sample. And there are a number of other breakouts available in the database report, including the unit work area, staff position, staff tenure, and all sorts of other information there. this concludes my presentation, and I am thrilled to welcome the Indiana Hospital Association, and they're going to talk about how they have used the SOPS survey and implemented it, some of the challenges they've faced and overcome, and how they've used it to measure and improve patient safety. Thank you.
Thanks so much, Jonathan, and good afternoon, everybody. My name is Madeline Wilson, and I'd like to thank you for inviting us to share with you our process for safety culture assessment and the addition of the workplace safety questions. Next slide. First, I'd like to share a little bit about the Indiana Hospital Association. IHA serves as the professional trade association with more than 170 acute care, critical access, behavioral, and other specialized hospitals in the state of Indiana. Our mission statement is to provide Indiana hospitals with leadership, representation, and support to improve the health of all of our citizens across the state. Next slide. Within IHA, the Quality and Safety Department believes that patient and staff safety is very personal. We provide quality improvement efforts at the local, regional, and statewide level, and believe that working together accelerates the pace of quality improvement. We also believe that data-driven transparency promotes accountability and changes for improvement. We'll share a little bit more about that here coming up shortly on how we're doing that. We also believe that visible and consistent leadership supports a firm culture of safety. Next slide. During our most recent refresh of our patient safety work, we likened our culture work to a river flowing continuously across all channels, and that diverges and converges, and sometimes it just stays together. Culture really has a place in harm prevention, also diversity, equity, and inclusion, healthcare partnerships, and we really try our best to link all of those things together through all of our programming. Next slide. So examples of this include our work such as a safety awareness toolkit. We have an infection prevention boot camp, maternal and infant safety programs, social drivers of health screening and data capture of Z codes. We have patient, family, and caregiver advisory committee work, and state and federal program collaborations. We link our work and speak to the connection of culture in all of this programming. Next slide. In 2008, IHA began offering the AHRQ hospital surveys on patient safety culture survey free to all of our members with the assistance of an outside vendor. In 2015, though, we brought it in-house to process ourselves, and we began managing the survey internally. We created survey templates for the hospital, the medical office, and ambulatory surgery centers in SurveyMonkey. And then post-survey, we provide the analysis, feedback, and do some personal coaching with opportunities for improvements identified. And we also provide what we call a tracking of results over time so that they can have on one sheet every year and how those changes have occurred. Along with their analysis report, we also share the tools that AHRQ provides, such as the resource list linked to all of the dimensions. And we strongly encourage the use of the database reports because this really gives a snapshot of what the rest of the country is experiencing. And also, we can use that so that they can show or see how they perform as a specific size hospital with other hospitals across the nation. Next slide. And I think it's suffice to say that we have all experienced many changes since the pandemic, especially as it has related to workplace safety and wellness. So in 2022, we decided to introduce the workplace safety survey questions. We actually added those questions to our SurveyMonkey platform. So it appears to be a continuously flowing survey with a break in between. And we started that work with a pilot of 6 hospitals. This was a year of very few surveys being conducted, mostly due to staffing issues, the unrest of the pandemic, and hospitals really needing to alter their normal survey timeframes. So we only conducted 17 surveys in that year, as you can see in this chart. Next slide. But in 2023, that all turned around. We actually conducted surveys for 38 Indiana hospitals, 3 out-of-state system affiliates, 289 medical practices and outpatient service sites, 3 ambulatory surgery centers, and we added 37 workplace safety surveys to 38 of our hospital surveys. We gathered so much data, and we're using that to build our workplace safety program, which Lori's going to speak to next. Next slide. So this survey process has really taken on a new meaning for us and our hospital partners. Healthcare facilities are really facing challenges, really in many aspects, especially as it relates to workplace safety and wellness, and they really need to find ways to evaluate these challenges. The barriers that are faced with doing this survey is that staff are really super busy right now, especially as they're short-staffed. And despite incentives being offered, such as pizza parties, department awards, or even personal gifts, such as a candy bar or a free cookie in the cafeteria, that's a big one, staff either don't have the time to complete the survey, or they really might be a little apathetic about taking the same survey over and over again. So, we really need to work with our hospitals to kind of help them encourage and support new ways of getting feedback. We have found, though, one thing that has helped a lot is that we offer the QR code for people just to scan that and go right into SurveyMonkey. And that has been very helpful because it really allows our staff to be able to scan that code and take that survey anywhere instead of being confined to just a hospital computer. Next slide. And although our participation numbers were the highest ever for 2023 for our hospital surveys, our scores were really some of the lowest. So we looked at these results through a different lens as we incorporated the workplace safety survey questions. And now I'm going to turn it over to my teammate, Lori Gert, who's going to share with you some of the results that we found.
Thanks, Madeline, and hello, everybody. Nice to meet you. Nice to see you. Lori Gert, Quality and Safety Advisor with IHA, Indiana Hospital Association. Next slide, please. So as Madeline said, she laid a great foundation with adding the workplace safety supplemental item set to the core survey that IHA offers. And so in 2023, January of 2023, the Indiana Hospital Association Board formally decided to commit time, energy, resources, and funding to a workplace safety and well-being initiative. And we call that initiative Safe and Sound, Safe Bodies and Sound Minds. Now, the initiative uses the American Hospital Association's framework for building a safe workplace and community. And you can see from the image on the PowerPoint that leadership is at the core of this framework. And then there's 4 surrounding foundational pillars. And no surprise to anyone, culture of safety is the first foundational pillar. Because of that, what the Indiana Hospital Association Board of Directors did is they said, we're going to commit to encouraging our members to include the workplace safety supplemental item sets questions to their core survey. Again, we can't mandate anything, but we can certainly promote and encourage folks to use that survey set. Next slide, please. So again, as Madeline said, we connected those questions to the Survey Monkey. They were added to the end of the hospital core survey. So the workplace safety questions were actually questions 42 through 63. This was decided upon instead of doing it as two separate surveys. We know that survey fatigue is real, and we had a pretty minimal survey response rate. So the core patient safety culture survey response rate for all of our Indiana Hospital Association members that took the survey through us was 42%. And the workplace safety items response rate was 41%. So not bad, not a bad drop off at all. Next slide, please. So 37 of the 38 Indiana hospitals that added the workplace safety supplemental item set to their core survey brings us, Indiana Hospital Association, with some beautiful aggregate data. So that data, those 37 hospitals actually represent just over 14,000 valid responses. So that represents just over 14,000 of our Hoosier healthcare workforce. So we're starting to get a feel, right, for what it's like for the state of Indiana around workplace safety. Next slide, please. So you can see that one of the areas that we could do some improvement in is this Dimension 4, hospital management support for workplace safety. We can see where Indiana, which is the darker green, aggregate Indiana data, is 5 points lower than that AHRQ database benchmark of 70% positive response for the hospital management support for workplace safety. Next slide, please. So let's look at that dimension just a little bit deeper and look at the item set. We can see here that it wasn't just one question with significantly lower positive response rates that was bringing us down at 5%. We were lower on all 3 of the items. So the actions of hospital management show that the safety of providers and staff is a top priority. Hospital management provides adequate resources. And then hospital management takes action to address provider and staff concerns about workplace safety. So we can see we're lower on all 3. And so we're like, okay, let's look at that. Let's see, while we know that leadership, the buck stops with leadership. And if you look at the American Hospital Association framework, with leadership being at the core, you know, it does start with leadership and stop with leadership when it comes to culture of patient safety and workplace safety culture. So let's look at some more data. Next slide, please, to see what else we find. So the other very obvious discrepancy in scoring is in Dimension 6, addressing workplace aggression from patients or visitors, where there is a 15% discrepancy. Now, this is interesting to me. So remembering that this dimension is reverse worded, right? So we're a positive response are folks actually disagreeing with the statement that there is a problem with physical or verbal aggression on this unit. So we dug a little bit deeper into this, and we saw that 34% of our respondents agreed that there was a problem with physical aggression in the workplace. And 44% of our Indiana respondents agree that there is a problem with verbal aggression in the workplace. So this is telling us that we have opportunity to improve, right? Next slide, please. But we wanted to look at some of the single measure items also. And we also wanted to make sure we weren't thinking about the workplace safety survey as an isolated silo separate from the core survey. Because as we can see on the core survey, under the teamwork dimension, the question of there is a problem with disrespectful behavior by those working in this unit is asked. And for Indiana, we had a 70% positive response rate compared to the national benchmark of 71%. But then looking at the workplace safety survey, the single measure item of addressing verbal aggression from providers or staff, where it asks in this unit, there's a problem with providers or staff being verbally aggressive toward other providers or staff. There's a pretty significant difference in between Indiana and the AHRQ national database. We have 61% positive response rate in Indiana versus 78% for the national benchmark. Now, Madeline and I discussed this data a lot in regards to looking at it as a whole. And we know that there's not a causal or cause and effect relationship here, but we always think about are the experiences of all these aggressions and disrespect, are they contributing to burnout? So next slide, please. Let's take a look at the burnout single measure item set. And this is a little bit of a different graphic because we wanted to show you how the Indiana Hospital Association is actually reformatting the survey results by using our data visualization tool, DataLink. It's a Tableau tool. And results are visualized in aggregate form for the state. So we can see for work stress burnout for Indiana, the percent positive response is 35.25%. The national is 34, so we're a little bit higher. We're a little bit more burned out in Indiana. But then you can see there's a facility level data. So for this example, this facility actually has a lower work stress burnout response rate. And then coalition. So the Indiana Hospital Association has 11 patient and safety regional coalitions. And we wanted to add that level of data to our data link report. Now, this is only as good as the number of those hospitals that participated in the workplace safety survey being in a particular coalition. So this is going to be incomplete data, but we know that. So next slide, please. Looking at all that data, looking at the workplace safety survey data, looking at the single measure items, looking at the national database versus Indiana aggregate database, we knew we needed to do something. And one of our whys to doing it has to do with this cycle of institutional support response. We know supported and satisfied staff leads to higher morale and lower turnover, which then leads to excellent patient care, which leads to satisfied and engaged patients and employees, and therefore a satisfied and joyful institution, right? We want to pursue interventions based off of our data that really create a satisfied and joyful institution. So that means we had to look at things from an organizational viewpoint. So RISE, or Resilience in Stressful Events, and Notice, Talk, Act at Work are two of the strategies that the Hospital Association decided to pursue because they have an organizational approach to these issues and because they're evidence-based and evidence-informed. We're not just picking things out of the sky. The other reason we like these two particular strategies is they fit under those composite measures, those dimensions, numbers 4 and 6, hospital management support, and verbal and physical aggression in the workplace. So we're trying to make sure that we're being very purposeful and intentional in addressing those areas where we knew we needed to improve, and there was opportunity there. Next slide, please. So let me just tell you a little bit about RISE, the Resilience in Stressful Events. This is a peer response training. So that means when there is an adverse event in an organization, that could be a workplace violence event, that could be a medication error, that could be a death of a patient. We all know those stressful events contribute to the feelings of burnout and workplace stress. Going back to the American Hospital Association framework, we knew we had to start with leadership. So we went to our board and they committed and appropriated funds for the Indiana Hospital Association to pursue this training for our members, to pursue the idea of embedded peer support teams to combat the effects of workplace violence and stressors on our healthcare workforce. So we were able to recruit 13 member hospitals to participate. And this took contracting with the Maryland Patient Safety Center. They are the owners and the trainers of RISE. RISE actually was developed by Johns Hopkins, and it's a 2-day live virtual training. As a result of this training and this cohort or pilot of 13 hospitals, those 13 hospitals represent 13,701 FTEs that now could potentially have in their access or at their access a RISE peer response training to adverse events in their organization. And we definitely plucked out pearls of wisdom here. Nothing beats firsthand experience. Engaging those 13 hospitals leaders in the first day of virtual training meant everything. They really got a solid understanding of what this is about and how it can help. What was difficult was recruitment. We have at the Hospital Association 170 members. We got 13 of those organizations to commit. And it's really, it's no surprise to us. Healthcare is hard. There's a lot of balls in the air. There's a lot of competing priorities. And sometimes it's hard to commit something that you don't fully understand yet, right? One of the things that surprised me was the organizational fears around confidentiality and reporting for a peer response program. So it takes a lot of discussion about what RISE is and isn't. It isn't therapy. It isn't an employee assistance program. It isn't counseling. It truly is an active and empathic peer listening to your stress. And the results from our 13 organizations have led us to next steps. We're going to continue RISE training, and we're going to add an adaptation to include asynchronous training modalities. Of those 13 hospitals and all the peer responders they trained, we're going to convene them into a quarterly community of practice so that we can really continue learning and track progress. And then, of course, we want to provide resources and we want to host subject matter experts for those hospitals, and then do another round with some new members and use our existing members as case examples. Next slide, please. So because RISE is a heavy organizational lift, we wanted to give an offering that was lower hanging fruit, lower effort, lower capacity needed. And so we have the American Psychiatric Association Foundation created a 35-minute online training course called Notice, Talk, Act at Work. And this is a training for people leaders. So it's for supervisors, managers, directors. This directly relates with that hospital management support dimension on the survey. If we can improve the skills of our people leaders, we may improve how our workforce feels supported and psychologically safe. Again, board interest, board support. They said, hey, pilot this with a small group first and see what they say. So we had 39 individuals representing 19 different member organizations take that 35-minute class. We had to contract with the APA Foundation to do this, and so they provided the electronic links to our individuals, with an evaluation being mandatory. And overall, after the 39 folks took the course, there was an overall rating of 4.36 out of 5 stars, so to speak. And in the comments, we got quite a few comments that said, hey, this really is good for leaders. We'd like to have this in our organization. So what that means is our next steps is that the American Psychiatric Association Foundation said, hey, because you really are piloting this and really marketing it to your members, we're going to offer your members a discounted offering on the price of the course. One of the things that's excellent about Notice, Talk, Act at Work is it can be integrated into many electronic learning platforms. So it's easy for our members to distribute that training to their leaders. One of the things that surprised me about this is we had 2 chief medical officers take the course. And I don't know why this surprised me, but it did. They actually were 2 of the higher scoring evaluations. So they liked the course and we appreciate that. Next slide, please. Last thing I just want to touch base on, and going back to the Hospital Association framework and the 4 pillars, is we really made our efforts and our strategies try and fit into those 4 pillars. So we had quarterly webinars, and each webinar represented one of the pillars. We had Laura Castellanos from AHA present on the Hospitals Against Violence framework. For mitigating risk, we had our Indiana chapter partner of the International Association for Healthcare Safety and Security present on hospital security and policing. We brought in friends from Michigan Medicine to talk about situational awareness as a violence intervention strategy. And then, of course, under trauma support, we brought in the Maryland Patient Safety Center to talk about RISE. So all of this is really trying to build a culture of nonviolence, a culture of workplace safety and well-being for our members across Indiana and the state. And it's been really inspiring and really exciting to do this work. And it all started with workplace safety data. So I appreciate AHRQ and they're putting that survey out. Next slide, please. And then I think it goes to Naomi next.
Yeah, thank you so much. My name is Naomi Yount, and today I'm going to share with you some findings from our work linking workplace safety culture with patient safety culture and 3 other outcomes. Next slide. We performed the analysis using data from the pilot test of the workplace safety supplemental item set for hospitals, which was conducted in 2021. This data includes over 6,500 respondents from 28 hospitals. Next slide. Okay, we explored the relationships between workplace safety culture and patient safety culture, the overall rating on workplace safety, job satisfaction, and intent to leave. So patient safety culture was assessed using the SOPS Hospital 2.0 survey, which has 10 composite measures, as John listed earlier, and an overall rating. We also looked at the overall rating on workplace safety, job satisfaction, and intent to leave. And these are all single item measures included on the workplace safety supplemental item set. Next slide. Overall, we found that more positive workplace safety culture scores were related to more positive patient safety culture scores. So we found that 63% of the relationships between the 10 workplace safety measures and the 11 patient safety measures were significant. Next slide. There were 3 workplace safety measures that were significantly related to all of the patient safety the patient safety culture measures. These were the overall rating on workplace safety, supervisor, manager, or clinical leader support for workplace safety, and management support for workplace safety. Surprisingly, the workplace aggression measures were generally not strongly associated with patient safety culture. But recently we heard of a study done by the Emergency Nurses Association that was published in April, which found that more than half of emergency nurses were assaulted or threatened in the past 30 days. So while these measures weren't strongly associated overall in our database, we wanted to explore if this was supported in our workplace safety data. Next slide, please. So the top row shows the composite measure addressing workplace aggression from patients or visitors, where the database was at 56% positive, showing that there was some need for improvement, as this was the lowest scoring workplace safety composite measure. However, when looking by unit or work area scores, the emergency department percent positive was only 18%, which was 38 percentage points lower than the database. So the next 2 rows show the individual items within this composite measure. So in this unit, there is a problem with patients or visitors being verbally aggressive towards providers or staff. In our database across all of the hospitals, it was 48% positive, where they strongly disagreed with this item. But in the emergency department, it was only at 13%. And then if we look at the next question, in this unit, there is a problem with patients or visitors being physically aggressive towards providers or staff. Again, the database shows 64% positive are those who are saying they strongly disagree that there is a problem with physical aggression. And in the emergency department, it was only 24%, 40 percentage points less than the database overall. So while the overall the workplace aggression measures were not directly or strongly related to patient safety culture, we are seeing a lot of variation by work units, and there may be more significant relationships within these particular units, something to look at in the emergency department. And so our findings do align with that recent article, and it sheds light not only on the importance of addressing this issue in emergency departments, and as well as examining your scores by work area or unit. Next slide, please. Okay, we also looked at workplace safety culture and the overall rating on workplace safety. So not surprising here, all of the workplace safety measures were significantly related with the overall rating. Our strongest relationships were with hospital management support for workplace safety, supervisor, manager, or clinical leader support for workplace safety, workplace safety and reporting. And this is a single item measure that asks, I can report my concerns about workplace safety without fear of negative consequences to me. So this safety and reporting, and then protection from workplace hazards. Next slide, please. We also examined workplace safety with job satisfaction. And here we found 5 of the 9 workplace safety measures were significantly related with job satisfaction. Those 5 relationships were relatively strong, with the strongest being work stress burnout, where higher burnout was related to lower satisfaction. And then we see hospital management support, workplace safety and reporting, supervisor support for workplace safety, and protection from workplace hazards. Next slide, please. When looking at intentions to leave, 4 of the 9 workplace safety measures were significantly related. We see these strong relationships between work stress burnout. Again, burnout was associated with higher intentions to leave. And then for hospital management support, workplace safety and reporting, and supervisor support, the higher perceptions of support for workplace safety and safer workplace safety reporting was led to lower intentions to leave. Next slide, please. So overall, higher workplace safety scores were related to better or higher patient safety culture scores, higher overall ratings of workplace safety, higher job satisfaction, and lower intentions to leave. And we had consistent and strong predictors of these outcomes. And we see, again, supervisor and management support always up there. Workplace safety and reporting is very important, and work stress and burnout. Next slide, please. All right, so if you want to learn more, just the first one is an article in BMC Health Services Research. It was just recently published, and that does provide more results on the patient safety culture and workplace safety culture in hospital settings. And then the associations between workplace safety culture and the overall ratings on workplace safety, job satisfaction, and intent to leave were presented at Academy Health last year, and we're working on a manuscript, so that will be forthcoming. Next slide, please. And now I'll turn it over to Lisa to facilitate the question and answer segment. Thank you.
Thank you so much, Naomi. I appreciate it. Next slide, please. So again, thank you to John and to Madeline and Lori and to Naomi for your informative presentations. We certainly do appreciate your expertise, your insight, and your knowledge. You shared just a lot of helpful information about use of the SOPS surveys. As a reminder, you may ask a question through the Q&A feature shown here. Look for the Q&A icon. We encourage you to share your name and or your organization, your role when you type your question. If you joined late, a replay of today's webcast will be made available on the AHRQ SOPS website. So let's get to the questions. We have a few that have come in. This one is for Naomi. How can an organization implement this survey internally and analyze the results without an outside vendor? Are there any guidelines that we can look for?
Absolutely. We do have a user's guide for each survey setting. So there's a one for the hospital, medical office, nursing home, ambulatory surgery center, and community pharmacy settings. And these guides walk you through the use of the survey, through web administration or paper administration, helping you decide which is the right way to go for your organization. It also tells you how to hire a vendor should you decide that's the right way to go. What are some decision points for hiring a vendor? And it walks you through how to analyze the data. We also have an Excel tool, a data entry and analysis tool that you can use that will analyze the data for you. And you can request that by emailing safetyculturesurveys@westat.com. And yeah, so it's great because it also compares to the latest database with that Excel tool. And of course, if you administer the survey and you want to submit to the database, we will provide you with feedback reports.
Okay, great, wonderful. We do have a question from Regina Ryan for Lori. What resources help leadership come on board?
The first resource that helped member leadership come on board was the leadership board of directors with the Indiana Hospital Association. So starting from the top, right? The other thing that helped was looking at the American Hospital Association's framework, where it's so obvious that leadership is at the core, and citing that, putting that kind of framework in front of leaders to show that you are the core of this culture and of these activities. So using a formalized framework that already existed, but then using your own leadership to influence and impact other leaders.
Okay, yeah. I have another question from Christina Wildrick, and this for Naomi also. What is the data on the rate of participation of staff as opposed to just the raw numbers?
All right, so I'll talk about the workplace safety. I'm assuming you're talking about that one, but we have in 2022, we have updated results from the hospital workplace safety item set, and it is available on the AHRQ website that does provide the rate of participation. So there were 40 hospitals included in those updated results with an overall response rate of 34%. And then if you looked at the response rate for each hospital and averaged across that, it was 39%.
Okay. Are there, Naomi, are there any costs associated with using the AHRQ SOPS surveys?
No, there are no fees associated with the use of the SOPS surveys. They are publicly available. I will just make a note. I know sometimes we have international users on these. If your facility is outside of the United States, you do need to obtain permission to use and or translate the survey. And you can do that again by contacting our technical assistants. I'll say it one more time, safetyculturesurveys@westat.com. Maybe somebody can put it in the chat too if you didn't hear me. I was talking quickly.
I have a question also from Imelda Wright. I'm interested in safety culture on operating room settings because it's one of the highest risk areas of healthcare. In the literature, however, many researchers use the safety attitudes questionnaire as opposed to the AHRQ safety culture tool for OR safety culture measurement. What are your opinions on the AHRQ tool for OR settings?
You can absolutely use the SOPS hospital survey in the OR settings. I know it is used there quite frequently. We do break out results for those settings. I see Madeline shaking her head, so if she wants to weigh in as well for the use in the OR settings, I'll turn it over to her.
We have done that before, actually for several different, we have done surveys for just emergency rooms. We've done surveys when a specific department, namely we had one very large facility with a large OB department. They had some poor scores. And so they implemented some performance improvement activities. And then we resurveyed just the OB team to see what their responses were. But we have also done that for a group through a hospital system of about 10 ambulatory surgery centers that we just did specifically for them as well.
Okay. All right. I have a question that I'm going to float to Madeline or Lori here. How do you address the apathy among employees if they feel the organization did not address concerns raised before?
Well, I have responded to that question for as long as I've been doing this work, which has been over 10 years now. One thing, as when I was in a quality director role at my hospital that I worked for, I constantly said, you have a voice, use that voice. And that's what I said to our employees. Being the middle person between senior leadership and the employees, I then had to say to senior leadership, you have to respond to these results that you get. And I also point out the comments that people put, because sometimes we kind of assessed some of our departments, and sometimes we had some departments that really kind of struggled with understanding the questions. Now I will say the questions I think are better to be understood in version 2 than they were in version 1. People felt like they were trying to be tricked, right? And so the apathy part is, you tell us what your thoughts are, and we are going to respond to you. So then we started doing newsletters, and it's safety news. And what we would include in that was, we heard you. And we might add on top of that what we called a stoplight report. So we listed things that are red, yellow, green. And we were able to say, we heard you, but this is not something that we can work on right now due to the need to work on this. And I will tell you that what we saw when we implemented that 1 year to the next survey year, we saw some great improvement rates in participation, just because, you responded that you heard back. And so we also coached our individual unit leaders. And so as working for the Hospital Association, I've done that same type of coaching with our hospitals to say, tell them you heard their voices. Look at those comments. And, you might have one hospital, we had like 15 comments about the parking lot being too dark. When when the day shift was getting off or the night shift was coming on, they got a light up, I mean, it made a difference. So apathy responds to letting them know you hear their voice, even if it's only addressing one concern.
Yeah.
I'll add to that answer because Madeline's been doing this for years and has seen repeated members. One of the things that I think you could very effectively say is, if you survey just to survey and do not implement any improvement strategies, the next time you do this culture of patient safety survey, your scores will be worse. And by golly, Madeline has seen this, where scores are worse. So the other, so you can say with certainty, if you don't do anything, if there's apathy amongst leadership to actually act on this. The other thing is to use the AHRQ resource. I mean, you guys created a wonderful process improvement goal setting template, and really helping your leaders recognize you're not going to address everything on this survey. So pick 1, maybe 2 goals and go from there. So it's about scope also.
Okay, great. Thank you. I do have a follow-up question from Imelda Wright regarding OR. Is there one that we offer for specifically for OR, or would I just use the hospital version?
Yeah, thanks. For a hospital OR, please use the hospital survey. If it's an ambulatory surgery center, you can use the SOPS ambulatory surgery center survey.
Okay. Are there any recorded webinars that have information on patient safety culture assessments in hospitals, and how can healthcare organizations effectively implement these assessments to foster a culture of safety, transparency, and accountability? I believe Naomi, that's for you.
And I'm happy to answer the first part. And if Madeline and Lori have any other insights, please please weigh in, but we do have a lot of recorded webinars on the AHRQ website. So if you go to the AHRQ SOPS website at www.ahrq.gov/SOPS, we have a whole page called SOPS webcast that have replays back to the dawn of time, or at least to the beginning of the SOPS program. And you can see all the replays there. Some of these focus on the like how to administer the SOPS surveys, how to use them for improvement. And there are resources both for the hospital setting and other settings as well. And we encourage you to look at those and peruse them at your leisure.
And we have supported those as well, that when people request that, we direct them to the AHRQ website, because there's some great, I mean, even the old ones are still good, right? I mean,
Right. Yeah.
so yeah, and we highly support that with utilizing the resource tools.
With with Naomi's information about how workplace safety could influence your culture of patient safety, that information, there are also workplace safety gap analyses and assessments. AHRQ has a really comprehensive one that could be looked at and used also.
I have one other question. Do you have a standard form for the SOPS 2 survey for all hospitals, or we must choose the questions we need and develop our own survey?
Okay, so if you want the survey to be like as it stands, the validated SOPS survey, you must use the entire SOPS core survey. Okay, no changes to the items, the response options. You can, however, make changes to the work areas, staff positions, or any of the background questions. If you want to submit to the database, you must be able to crosswalk them back to the core survey's questions. But yes, you must use the whole thing. It was validated in that way. And in order to be a SOPS survey, you must use all those items. You can add questions of your own as well.
Right.
We have SOPS supplemental items, as we've heard today, the workplace safety item set. You can add those. You can add your own custom items. They must be added after the core survey. So please don't intermix them in the survey. They must be added after, and you should put them before the background questions. So on the AHRQ website, SOPS website, there is guidance for how to do this, how to administer it. If you want to order a bunch of supplemental items, we have guidance on which order it should be. So yeah, thank you.
Okay. And just one more question, quick question. Are there any tools available to help the organizations take action on their SOPS survey results?
Yes. So I think it was just mentioned a minute ago. We have an action planning tool just for this purpose. So, and it was just updated based on some feedback we've had from users of it. So the tool offers guidance that help you walk through to developing an action plan for your unit, your department, your facility. You can also, we have an action plan template that you can document your process. In addition, we have improvement resource lists. So these lists contain websites that are publicly available for resources to help improve scores. So our improvement lists are sorted by composite measure. So if you, in your action planning tool, decide you need to work on non-punitive response to error, you can go to the improvement resource tool, look at non-punitive response to error, and find the resources that are publicly available to make improvements there.
All right, that's very good. So I believe we are just about at the hour. So I want to thank all of our speakers today, Naomi and Madeline and Lori and John. Next slide, please. So thank you to everybody who has attended today. I think we've gotten some really good informative information. A brief webcast evaluation will pop up when you close out from today's webcast. Please take a moment to provide us with your feedback. as it helps us to improve our offerings and to plan future events that meet your needs. So thanks again for joining us. This concludes today's presentation.